Good morning, everybody, and thank you for joining us for the next one of our Meet the Specialist series. We have with us today the lovely Dr. Remy Glowinski, who is a psychiatrist, consultant psychiatrist with extensive expertise in adult psychiatry and an interest in treating depressive conditions, bipolar disorder, anxiety disorders, and work and accident-related traumas. So this is very topical. We know that he writes a delightful report. And we're very, very happy to have him on our panel. The purpose of these little chats is to introduce our specialists as real people to our clients, so you can see what they're really like behind the paper. So without further ado, I will hand you over to Dr. Glowinski. He'll do a little introduction of himself and his areas of expertise. And then at the end, there will be an opportunity to ask a question or two if you like. May I ask that you please remain muted until he's finished speaking, and then we'll have some time for Q&A. Thank you so much. Over to you.
Thanks, Michelle, and thanks for the opportunity. It's wonderful to speak to all of you today from home in Melbourne. First, I suppose I'll talk about my general experience. I've been in psychiatry for about 20 years, initially training in general psychiatry, moved to private practice in about 2008. At the same time, I also commenced a job at Forensic Care, which is the Melbourne criminal forensic service. So we provide psychiatric services to prisons and court reports. And that's where I first got I dipped my toe into report writing. I still do criminal forensic reports, but I've also shifted attention through my private practice to other types of civil forensic reports. So in my private practice, I've seen a range of conditions. Over time, I've focused on, as mentioned, bipolar disorder, mood disorders, and trauma-based conditions. And I suppose I can now say I've got pretty extensive expertise and experience with the treatment of those conditions. And over time, as I said, shifted towards provision of independent reports firstly in the work injury area, and then in personal injury, medical negligence, and also occupational psychiatry. So I do a lot of fitness for duty assessments as well. So I suppose that's a brief introduction to my experience and to my interests. As I said, I'm still seeing criminal stuff. If any of you happen to be in that area, I do find them interesting. But my core medico-legal work is more in civil psychiatry, injury matters, fitness for duty, negligence, and insurance claims. So I'm happy to field any questions about any of those topics. I have a fairly broad range of interests, and I can't claim to be absolutely at the top of expertise in every single one of them, but I have a broad range of interests, and I bring that to my report writing and my work.
Dr. Glowinski, one of the questions I wanted to ask from you, and I often ask this of our psychiatrists on our panel, is in terms of the objective to return injured workers to work, or to help people to attain their pre-injury homeostasis, if you like. How does that go in your reporting? Is that how do you look at that objective from a psychiatric analysis point of view?
Well, I think there's, I suppose, two aspects to what you're asking. You're sort of asking in terms of treatment. My treatment approach is certainly one where I'd like to get people back to work as soon as they are capable. I think in terms of independent assessments, I realise that that's not always possible, depending on their level of incapacity, and to assess, I suppose, objectively assess their incapacity at the time of the interview, and then to see potential pathways back to work, notwithstanding, I suppose, the likelihood of those pathways. So we're trying to put a sort of a figure or an idea as to how likely pathways are. And how realistic that is. I'm not sure if that's completely answering your question.
It's good. Look, another person who's unable to attend today asked me to ask you about telehealth assessments. Now, the anecdotal evidence we have from psychiatrists is that many of them were a little concerned about that initially, and felt that face-to-face was better for assessing non-verbals. But with everything that's happened with the pandemic, where it's become almost the norm, many of them are actually finding that people, particularly people who've suffered some sort of a trauma, are actually more relaxed and forthcoming on a video link assessment than they would be if they'd had to travel and turn up at rooms and speak to somebody face-to-face. What's been your experience?
I think the overall experience has been very positive. I think that it's a wonderful addition to the modalities of assessment. It's not for everyone, and I think some people do prefer, in terms of patients, I'm quite comfortable seeing people either via video or in person. Some people prefer to be seen in person, and they like the personal touch, so to speak, and seeing the person that's assessing them directly in their environment. And others are much more, as you say, comfortable at home with supports nearby. And you know, the lack of transport and other things that come with that. So I think it's a case-by-case basis. I'm comfortable doing either. And I think in certain situations, it is better via telehealth and others not. It's really an individual sort of preference, really, on the base. I largely go on the preference of the client. I don't mind either way.
Lovely. And before I let everyone else have a chance, I have one last question that's come in. Could you give some information or some advice from your point of view on what makes a good letter of instruction for a psychiatric assessment?
It's good to have a summary of the circumstances, so the reasons for the assessment, basically the context. I think that's always nice to have a reasonable summary of that. And I think also then the organisation of the documents helps a lot. If there's at least some reference to which documents are most relevant, and perhaps which aspects of those documents might be particularly pertinent, I think that's helpful, especially when there's, you know, a large tranche of documents of, you know, hundreds or thousands of pages. And I think then questions pointing towards what is wanted. You know, I think that most letters of instruction are very good in doing that. Some are more generic, and they kind of then leave it a little more open. I think that's where psychiatrists, or at least I, find it a little bit difficult to target my thinking. So I suppose some individual attention to questions can be helpful, and most letters of instruction do have that.
Terrific. Thank you so much. So people, if you would like to unmute your microphone and ask a question, please now feel free to do so. And if you don't know how to do that, it's at the bottom left hand of your screen. When you scroll down, the menu should pop up. And often in my experience, when there aren't any questions, it's because you've actually answered them. So I've actually got another question I wanted to ask. In relation to accident-related trauma, are these motor vehicle that you mostly have been doing, or is it other, like industrial accidents or other workplace accidents?
Both. So I think probably more workplace to this point, but I certainly have done many motor vehicle accidents as well. So yes, I suppose I can say both. I've also done more specialised circumstances, such as victims of crime, and I suppose it's more of a niche area, but majority work, secondary vehicle.
And which ones do you find, just anecdotally, would you say workplace accidents create the worst instances of trauma conditions, or would it be motor vehicle accidents?
I think motor vehicle probably has more, I was going to say genuine trauma. It's different things. I think traumatisation needs to be explained a little bit more, because I think there's the general conception of trauma as a broad psychological response, whereas most psychiatrists really think of trauma as flashbacks, nightmares, and a very discrete constellation of symptoms. And it's sort of broadened in the general parlance now, traumatisation, to refer to people who are, you know, obsessed or ruminating over workplace circumstances. So I've seen PTSD ascribed to someone who's mulling over managerial conduct, for example, that they think is unfair. And I've seen that labelled as PTSD. I think that type of condition is more often seen in workplace matters, you know, where there's some sort of industrial conflict, and that the client may see that as a trauma, But I think as psychiatrists, we don't view it the same way. But in terms of the PTSD type conditions, I think they're more often seen in vehicle accidents. Sometimes at work, I have seen people that have had life-threatening accidents or injuries at work and have developed a true PTSD. More often, it's the ruminations, the negative cognitions that are sort of more prominent in the workplace circumstances.
And so in a situation where it's not a true trauma in the way that a psychiatrist would immediately think of a trauma, as you say, it's somebody who feels they've been badly done by as a result of business decisions or management decisions, and they're upset by it, they're resisting change, or they're not accepting of negative feedback or of something structural in the business. Do you find those ones are very hard to recommend treatment or to look at a way forward?
Well, I can recommend treatment. That's not hard. I suppose the difficult part is whether the individual involved sees it the same way or views treatment as a pathway to some sort of reconciliation of whatever's going on. I think more often they want to punish the employer, and they might have justified reasons for feeling that way. I think if there's something terrible's happened at work and they've been victimised, then you can understand why someone would feel that way. But it does make individual treatment less promising. If there's no structural change accompanied with that the person or individual is going to be satisfied with.
Mm-hmm. And another question I have for you, sorry, it's all me. These are ones that came to me in email. So when, particularly with complex matters, perhaps medical negligence or public liability or other ones like that, do you find the value of also having a discussion with the lawyer or case manager during the process to be helpful?
I haven't had that happen too often, so I can't say I have extensive experience of discussions with lawyers. You're talking about prior to the assessment or after?
After the assessment and before the report writing.
I can't say I've had that happen too often, so I can't really offer an opinion about that. It's nice to get a sense as an independent psychiatrist that I'm remaining independent. So that I'm not sure whether that would encroach on that independence. That's not to say I'm not open to conversations like that, but I have to be mindful of keeping my independence from both parties. Yeah.
Good point. It's because it's something we're certainly noticing, particularly from lawyers at the moment. I've got a question pop up here in the chat. Does Dr. Glowinski accept briefs for medico-legal examinations for historical sexual abuse claims?
I thought that would come up. There's so much of that going around. It's frightening. The short answer is I do them, but I'm so chock-a-block that I'm not accepting new referrers, just to preserve my time and my mind. I do them. I've done many, but I have had to limit the referrers on that one.
Look, I think that's certainly something that I hear from other specialists in this area as well. Esther, if you wanted to send me an email, I can give you some details of a couple of other specialists as well, who do work in this space, but all of them limit the amount that they do, not only because of how busy they are in their clinical practice, but also because these matters, as you can imagine, are often quite distressing and confronting. But I'm happy to have a discussion about any of those matters with anyone. Dr. Glowinski, we are at the end of our 15 minutes. So I thank you again for making this special time for us. And now our people can meet you, see more about you, and seek to book with you, which I'm thrilled about. If anyone has any other questions, please feel free to email me anytime. I am available. And thank you so much. Have a great rest of the day.
Thanks very much.
Stop.